Hello and welcome everyone to our True Facebook Live. I am solo tonight. I usually have my lovely partner, Dr. Bittner, but she is away today. So we thought we could use this time dedicated to my main focus and center of attention, which is weight management, metabolic health, and using all of our tools that we have available. I am Dr. Celia Egan. I'm the Director of Obesity Medicine and Metabolic Health at True Women's Health, where we take care of women of all ages, 18 on up. And I, started my career in internal medicine, which means that I learned to take care of adults. Some of those adults were sick in the hospital, and some of them were not sick, but on the outside. The first couple of years of my career, I actually was in the hospital, and I saw a lot of people die from chronic illness, and I knew that that was not for me. And so I did a 180, and I've gotten super involved in preventative health. Through that journey, I've got board certified in obesity medicine, which basically means I really know and understand all the biochemical mechanisms for why our body holds on to weight inappropriately, how our body maybe doesn't necessarily give our blood sugar out from our liver in an appropriate way, leading to the chronic diseases as prediabetes or type 2 diabetes, and a lot of other kind of chronic diseases that we think of and plague patients in this modern day. Tonight, we're going to talk a little bit about weight management in general. We're going to focus on some of the new tools that have come out. This is meant to be interactive. So if anyone has questions, we can follow those questions and answer them if people would like, and talk about all things weight today. So let's get started. So first, we love just to talk a bit about our goals and where we want to be. And at True Women's Health, we call that our picture of self. And so all of our patients, we talk about their picture of self for their body composition. What is really interesting and what we've learned is that there really isn't one right answer for every woman. A lot of the times we use numbers such as BMI, which is a ratio of your weight to your height, as sort of cutoffs, and it's a way of categorizing patients. But I'll be honest, it's not really tried and true as clinically impactful of where a patient is. It's a great tool to use for public health because it's cheap and easy. It's super available to look in charts and put people in categories. And for watching trends, it's an easy way to watch trends. But when you're in the room with a patient, it isn't always necessarily the best tool, because I can have a patient who maybe is losing a ton of weight and they feel overall so much better, but their BMI still may be high. And honestly, there's not a tremendous amount of research to say that that BMI has to be at a certain spot. So for you at home, right, even just thinking about where you want your body composition to be. And for some women, that may have nothing to do with where their fat is at, where their body fat's at. It may have to do with more with increasing their muscle mass. And that may be a huge focus. It's hard to believe that, someone wouldn't want to think about body fat, because a lot of women come into our office talking about that, trying to find ways to reduce body fat. Particularly, it gets frustrating because we hear a lot that there'll be a phase of life of which body fat expands. So a lot of times this can be pregnancy, definitely perimenopause and menopause, sometimes an injury or a major life stressor. COVID was a huge example, right? Where we had this huge kind of global stressor, and it was really impactful in people's day-to-day lives. They completely changed their lifestyle. Maybe they were going to the gym after work, and now they're not driving to work, and they're not going to the gym. And so now their life is completely different. And we'll see a rapid time when people sort of gain a lot of weight. When women will talk about times where they've gained a lot of weight, and then it's very difficult to sort of, even with some of those lifestyle changes that were made before, get weight off. I know in particular, as we're moving into warmer weather and we're starting to think about wearing less clothes, particularly if you live in Michigan, it can feel frustrating because all of a sudden, like, our shorts don't fit as well as they used to. Thinking about putting a bathing suit on feels a little uncomfortable, right? And we're now thinking a lot about our body composition and what we can do to change that. Let's talk a little bit about why our body holds on to weight at all, right? So our fat cells are there to provide us extra energy for the times that we're not eating. We do need fat, right? It is a part of biology and how our bodies have lived, and humans have been able to make it this far. Um, the size of our fat cells, both in number and the actual size, is really tightly regulated between a couple of different organs. So our brain is there to kind of oversee all that's coming in. It gets feedback from places like our small intestine that's kind of taking up the food that we've eaten, our liver that's there to take that food and redistribute it. Maybe it's going to distribute it as a molecule called glucose, which makes up our serum glucose or our blood sugar. Maybe it will repackage it as something called a fatty acid, which are big, long carbon chains. The point of a fatty acid is to be able to move a lot of energy around really quickly. It has to be all packaged up into basically these cholesterol packages. And that's what our liver secretes. And that's what we look at when we look at cholesterol levels. Our muscles are there and part of this whole system because that's where the majority of our energy goes, is to our skeletal muscle. But it only gets all that energy when all the other organs are fed. And so the input of energy or input of glucose into our muscle cell is really tightly regulated to a hormone called insulin. So okay, here we are, right? We have our brain that's trying to figure out what we need. We have stuff coming in, it's being all repackaged, stuff is being utilized. There's all these hormones zinging around from all of our different organs trying to figure out what to do. Our fat cells then basically get the sum of all that messaging. So maybe our brain says we need to be into a weight gaining state, grow, 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 right? Maybe our fat cells are only hearing the hormone called insulin, and insulin basically locks a fat cell in place. So maybe there's other parts of the body that are sending a signal to shrink the fat cell, but if you have too much insulin, it's just going to hold that fat cell into place. And there's a variety of other things. A common one that women think a lot about is their thyroid. So if your thyroid is off, meaning if you don't have enough thyroid, it can be very difficult to lose weight because those fat cells just don't have that right signaling. So that's sort of a brief overview of how our body sort of holds on to extra weight or why it's making its choices. Then, so if that's how it works for men and women, we're going to throw on this extra layer of our sex hormones. So our ovaries are secreting sex hormones, estrogen and progesterone, testosterone. Estrogen in particular is telling our body, like, what's happening with this whole process of having a baby? Am I ovulating? Am I pregnant? Am I breastfeeding? Right? And so estrogen is there to tell the whole energy system, really our whole body, kind of what's going on with this process. And it can feel really impactful, maybe in small variations as a woman is in reproductive phase and you get these ebbs and flows of those hormones over time. But it may feel super impactful during perimenopause and menopause, where during perimenopause, those estrogen levels just skyrocket and bounce all over the place. And then to menopause, where they basically go to zero. That's when this whole energy system, which then can lead to fat accumulation, really can go bonkers. And so I know we've talked a lot in our Facebook Lives and at our practice about the importance of knowing where you're at in terms of your phase of ovarian function and how that can impact many other aspects of your health, but in particular, the body composition and the amount of fat cells that we have. So when I have a woman that comes in and tells me, oh my gosh, I've gained sort of this extra weight, I'm sort of in my mind thinking about all this different messaging system that's going on and trying to understand where that patient may be at or where that woman's at and how we can use any other of our tools that we have to intervene. One of the major questions that we talk about if we're thinking about the organ of our brain is our relationship with food. A lot of the times people will come in and they know what to eat. They're trying their best to get it, healthy food in the house, but they're struggling with such high hunger or such high cravings that being able to make a good food choice is really a struggle. And even though they maybe know exactly how many calories they have, it's just really hard to outpace that high hunger or high craving signal from your brain. And it becomes like almost like an out of body experience where we can really overdo certain foods. In general, most of these foods that we're overdoing tend to be ultra processed foods or foods super high in like simple carbohydrates or simple sugars and fat together. So this is like, our chips and cheese or our cheesecake or our pizza, where we really get all those flavors together. That sort of lights our brain up like a Christmas tree. And then it's very difficult to sort of keep in control of all those different of the quantities and the types of food we're eating. Definitely, if over my 10 years of instructing patients of dietary changes, it's really a hard sell to tell a patient, okay, why don't you just have like boiled chicken and boiled broccoli, and the rest of your family is going to have pizza. And you're going to sit there and you're going to see the pizza and you're going to smell the pizza and you're going to see like the gooey cheese dripping from their mouths, but you kind of have to sit with boiled chicken. That's really a hard sell. And some women can get by with it for a couple of weeks, but a lot of the times just our brain will not allow all those triggers of, oh my gosh, I just want pizza to continue on. And eventually we just sort of change our mind and we're just kind of forced to have that pizza. So when we're talking about a patient of losing weight and making food choices, one of the most important things that we like to talk about is sort of our relationship with food. In addition, we talk about the importance of exercise and moving our bodies. Obviously, the muscles are really an important process or important part of maintaining that energy balance. And although your muscles don't have direct feedback to your fat cells, it's this indirect loop of them taking blood sugar up, therefore changing the hormonal system that then can impact your fat cells. The second piece is the more we're sort of moving our body, kind of the better our brain feels. And again, that sort of impacts our relationship with food. It's really hard to tease out the chicken or the egg between all these different things, because a lot of times all this stuff is happening at once, either in one direction or the other. A lot of the times patients will come in and they're ready to make a change. So they're making dietary changes and they're starting to work out and they're thinking about themselves and they're paying attention to their movement and what they're eating and how they're feeling. And that can lead to sort of good changes, or the opposite happens, right? You get way too busy with work, way too busy with family. Exercise falls by the wayside, meal planning falls by the wayside, stress gets cranked up, and all of a sudden we're just kind of eating what's ever there. Most of the time we're overeating, right? And then again, it just sort of becomes this snowball in the wrong direction, and sometimes we can see weight gain. It's just so fascinating to see the connection between both those things. And it can be really helpful to kind of slow the process down and think about them individually as you're starting to sort of make lifestyle changes as to what can be the next best step to get started. Of course, if you're in that phase of ovarian function where we're talking about huge hormonal shifts with perimenopause or menopause, it can be really helpful to understand the role of maybe replacing some of those hormones, if that makes sense for you, and if that would be a safe choice, if you would be a safe candidate. Because although it hasn't been shown to directly impact weight, we have seen that women feel as though it gets them just moving in the right direction. Again, what part is it? Is it that they're sleeping better because they no longer have night sweats or hot flashes? Is their mood just a little bit better and that just makes making food choices a little bit easier? Or is the hormone directly impacting their whole energy flow system? It's very hard to tease out. We just know that women tend to feel better and we tend to see a shift in their body composition. Of course, not always, but sometimes it can be really helpful. And then we're going to lead to the topic of the night, which I know a lot of people love to talk about. Of course, over the last sort of 5 to 10 years, there's been a huge advancement in the field of the anti-obesity medications. I'm going to give just a short, brief history about the anti-obesity medications because I think that it's important to know kind of the stepping stones of where we've been. So the anti-obesity medicine field has been going on for about 30 years or so. In the beginning, we had some medicines that maybe worked, but had a lot of side effects. For instance, in the 1990s, there was a drug called fen-phen, which was a combination drug of ephedrine and phentermine. One of those drugs, the ephedrine, caused right-sided heart failure, so it was pulled from the market. they actually took the good part of fen-phen called phentermine and have been using that actually in combination with other drugs. One of those is called topiramate, and that actually still to this day is FDA approved to help patients lose weight. In general, we see modest sort of weight loss, anywhere from the 8 to 10% weight loss range. For some patients, about a quarter of my patients, it can be really impactful. And a long time ago, we used to think that, it was something that you could only take for 3 months and then had to stop. That is definitely not what we do within the obesity medicine space anymore. And I've seen patients that have taken it for years and done just fine because it's part of their obesity medicine plan. And we're correcting sort of some of that signaling in the brain. So we had our fen-phen that didn't really work out so well. There was some kind of off-label use of metformin that was helpful. And then again, the topiramate that we've combined with phentermine to make Qsymia that was helpful. And then came along like the 2000s, the drug Ally, which blocked the fat absorption of fat from our diet in our GI tract. This had some promise because it did show that there was some good success with weight loss. However, the side effects were horrific. People were like pooping their pants and it did not go well. So in general, I don't think I've had anyone on Ally for the past, over 10 years. And I don't think that will be a drug that will be used any further, although it's still sort of available and out there in the rest of the market. Then there were some drugs that really targeted the reward system in the brain. One of those drugs was called Contrave, which we still use to this day and have good success with patients who are emotional eaters. Contrave is a combination drug of a medicine called bupropion, which we use for tobacco cessation and depression, as well as a drug called naltrexone. Believe it or not, naltrexone in our brain is an opioid blocker. We use a small amount of the same active ingredient that's in the drug Narcan that we give people when they overdose on opiates. Of course, this is in a much smaller amount. But what we found with low dose naltrexone is its use blocks some of that reward center pathway, which makes kind of overdoing some of those ultra processed foods less rewarding, and therefore it just doesn't feel as good, and people are able to make a bit of a change to their food habits, particularly when people are feeling, the word I like to use is bingy, right? So that's like maybe not necessarily fitting into the definition of a binge eating disorder, but you're a mom, you've worked all day, kids are screaming, and you're just in the pantry and you're just like animal crackers, bop, 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 right? And I just like can't stop eating, and like half the bag is gone. You're like, oh my gosh, like what did I do? I wasn't even really that hungry, but I couldn't stop eating those animal crackers, and I'm so stressed. That's kind of what I've coined as just being bingy. And so Contrave has been really helpful for that kind of stuff. In addition, there's also an ADHD medication that we use called Vyvanse. That's also been impactful in terms of that binge eating. It's a bit hit or miss. Some patients, if they already have ADHD, it's a great drug to try out to get them started if they're also struggling with some of those binge eating disorders. There are a couple of other drugs. Belviq was one that was actually pulled from the market with some concerns of cancer risk. And for the most part, that was kind of what we had to work with. And then came the new class, which we're going to call NuSH therapy, or nutrient stimulating hormones. What these drugs were drugs that mimic some of that signaling, particularly the signaling that's coming from our GI tract. And it goes to all the different organs to basically cue up the body to let them know that there's food there. So it goes to your brain, and it's like, brain, be less hungry. Don't think so much about sweets. Liver, let's repackage up the sugar and fatty acids in a different way. Muscles, we have so much food. You're okay to run. Move that sugar into the muscles. Fat cells, we don't need you. We have food. You're okay to shrink. And it impacts other organs in sort of a similar fashion. Initially, it was FDA approved because we started treatment for type 2 diabetes, and we found great success, probably mostly via the actions of the liver and then the brain with the ability to make better dietary changes on improving blood sugars. But one of the most exciting side effects of that was patients actually were able to lose weight. This was a relatively new phenomenon because a lot of the type 2 diabetes medications that were used up to this point actually caused a lot of weight gain. And it was one of those things that it felt like a snowball totally in the wrong direction and felt really defeating for these patients who had type 2 diabetes. That was sort of this choice, like, do you either get your blood sugars under control or do you gain a bunch of weight? And like it just didn't feel ever like a good choice. And so this was really exciting to have a class of medicines that could control your blood sugar, but also help you lose weight. The first generations of these drugs, we saw modest weight loss, but of course, they took some of those molecules and have continued to sort of enhance their weight loss success. So, where are we at in 2025? Where are we at is there's two main drugs that are on the market. One is the active ingredient semaglutide. It goes by the names Wegovy or Ozempic. Ozempic is sort of all over the news, but it also has other names associated with it. It again is one molecule called a GLP-1 that is a hormone that leaves our small intestine and does all those mechanisms that we talked about. It shows pretty impressive weight loss results not seen by any of the other drugs. Approximately 16% was what we saw in some of the trials on average. Then a second company came out with another drug with the active ingredient tirzepatide. That's under the brand name Mounjaro or Zepbound. Mounjaro is for treatment of type 2 diabetes, and Zepbound is for the treatment, just for simplicity's sake, for right now, for obesity or someone who needs to lose weight. And Zepbound or tirzepatide, not only is it a GLP-1 receptor agonist, but it is also a GIP receptor agonist, which is a separate hormone. So we are going to call this dual agonist therapy. So now, as you can see, we're sort of building on to the signaling process that's being given to our body. Now, one of the things that is so exciting is tirzepatide actually had even more weight loss in the clinical studies than semaglutide, which was about 22% body weight loss on average, with some patients losing up to 33 and 40%. And I can tell you that is very close to what I see in my practice, that I have seen women lose over 100 pounds or upwards of 33% of their body weight. I want to imply that this is not every patient, but I have seen it with some of our patients, which just, up until about 5 years ago, that was completely unheard of, unless you were doing bariatric surgery. And so now for the first time, we have medications that are getting us the success of bariatric surgery, which is really exciting. In 2025, one of the other layers to these anti-obesity medications or this class is they're also getting FDA indications for other disease processes. So for instance, semaglutide is FDA approved to prevent a recurrent heart attack or a stroke, which is crazy to think about, how this drug that's impacting our blood sugars and impacting our weight is also helping prevent recurrent heart attacks and strokes. Zepbound was FDA approved for treatment of severe to moderate to severe obstructive sleep apnea, which is so kind of, again, interesting of all these overlaying factors that are there. So obstructive sleep apnea is where your airway gets inflamed and closes down. What they saw was that patients had less inflammation in their body, and overall they had less times throughout the night that they weren't breathing. So the FDA thought that was enough evidence to also approve Zepbound or tirzepatide for treatment of obstructive sleep apnea. Both these companies that make these drugs are also going after other indications, particularly something like fatty liver disease, where we can see fat buildup within our liver. Polycystic ovarian syndrome is another target. Osteoarthritis is another target. Chronic kidney disease is another target. So there's a lot of other disease processes that these drugs will have treatment for. In particular, probably one of the most broad spectrum one will be treatment for prediabetes. So prediabetes means that your blood sugars are not normal, but they're also not at the level that would meet criteria for type 2 diabetes. And what we saw in a paper that was published later in 2024 was that patients who were on Zepbound that had prediabetes, even if they had comparable weight loss, majority of them did not progress to type 2 diabetes. And in fact, most of them corrected their blood sugars. We've talked numerous times, and I think you can find numerous doctors who will talk with you on and on about the importance of having stable blood sugars. So for the first time, that really feels like something impactful from a medication standpoint that we can use to sort of prevent that transition to type 2 diabetes. So yay, here we are, 2020, 2025. We have several different drugs that are really impactful. What is the hiccup? The main hiccup that I'm sure all these ladies who are watching and have even thought about already know is cost and coverage and availability. For the first part of this generation, particularly in 2023 and 2024, we had a lot of issues with stocking. I don't think these companies thought that there would be as much demand for these drugs as they were, and they had trouble keeping up with stocking. And I know my team was calling different pharmacies across the state trying to find people medications. And that was a real barrier. Because of the stocking issue, the FDA placed these drugs on the shortage list. With being on the shortage list, allowed legally for companies, compounding pharmacies, to go ahead and be able to try to fill that gap. And what we saw was a whole array of basically non-FDA approved versions of these drugs that were available, both via doctor's offices, but also from online companies, also maybe not even associated with a medical professional. And that caused a lot of sort of controversy and stir. At our practice, we've chosen not to go down that pathway of prescribing compounding medications, not because we don't want patients to have access, not because we don't think that they're important, mostly because there's just been so many issues with the compounding medications. And, I'm going to give a brief overview of some of my thoughts about it. I think this is really controversial. And again, I know how frustrating it can be to not get coverage. I know Jill just posted a comment about how frustrating it was to not even get it covered for type 2 diabetes, where we've seen such drastic improvements. And trust me, I know, Jill, it has been overwhelmingly frustrating for all of our patients. When thinking about the compounding medications, some of the reasons why I pause, right? Reason number one, the doses really can vary from not only shot to shot, but also month to month. And one of the things we get concerned about is that 1 month a patient could have very little and have it be not so impactful, to the next month they could have a huge dose, and then they see a huge impact of side effects. The main side effects that we see from any of these drugs of the same class is mostly GI side effects, where we have patients who can have lots of nausea, diarrhea to constipation, reflux, you name it. And it can be really concerning if they don't know what dose they're getting from month to month. The second major reason that has caused a lot of pause is there's been some research studies that have shown some impurities within the actual drug. So much so impurities that they weren't, some of these scientists that ran them through the different machines to figure out what exactly they were, and taking random samples, they weren't even able to identify some of the molecules that were in them. Anytime we're giving our body a molecule that we don't know what it is, we worry about a couple of things. One, we worry that maybe it's pushing basically the growth of cancer cells, or just not letting our body do its natural thing in terms of cancer. And we all know that that's not a good idea. The second major reason why we think about it is we get concerned that it may activate our immune system. I was struggling to come up with a way to use this in words. And so I'm going to direct us to a video that I made where I drew a picture, because I think that it does a much better job of explaining what I'm talking about. So we're going to play a quick video of an overview of the reasons for why we want to think about using some of these off-label medications in terms of our immune system. We want to talk today a little bit about our concerns with some of the medications that have been known out there in the environment as the compounding GLP-1s. I first just want to say that we're not totally against compounding pharmacies. Compounding pharmacies have a really important place in our medical system. Typically, a compounding pharmacy would take an FDA-approved medication and maybe make it into a different form. Maybe the dose needs to be lowered. Maybe it needs to be made into a cream, and right now it's a pill. Compounding pharmacies hold a really important place within our medical space. And anything we're going to say next is not about compounding pharmacies, because those are really important. What we're concerned about is the way that these medications are being presented is not from a compounding perspective. They're actually taking new drugs that are being made and labeling them as some of the FDA-approved versions. Another thing that's really important to recognize is that these are not generic medications as they're being listed. Generic medications are medications that are off of patent, so they're no longer brand name, and any company can make that medication, but all those medications are still FDA approved. So remember, when we're talking about using compounding GLP-1s from pharmacies that are not FDA approved, they're not generic medications, and in some ways, they're not even should be described as compounding medications. So what are some of my main concerns about why these medications are so harmful possibly? And we chose to draw this picture out because I think a picture is very powerful. So first we're going to start off by talking a little bit of why we gain and lose weight. Remember everybody, our brain is really involved in this whole process. It's taking feedback from a lot of different organs to determine how much fat we need in our body to maintain an energy supply. A couple other organs that are involved are our liver, our GI tract, right, which is there to take up all the nutrients that we're eating. All these organs are talking to each other and getting feedback from different hormones. One of the most important group of hormones that we've discovered in this whole energy balance system is a group that we'll just call the GLP-1s. That's an oversimplification of a lot of different hormones, but for simplicity's sake, let's just say that that's what we're going to call them. How these hormones work is, let's just say that on the cell of a fat cell, there's a receptor. Our GI tract secretes a hormone. And let's say that our natural GLP-1 that our body makes looks a little bit like this. It's a molecule with a part of it that will fit into the receptor. And then there's another section, we'll just call it a tail, that is around that our body is used to and understands. The companies that have made these drugs, such as Eli Lilly or Novo Nordisk, has spent decades trying to find the technology to make these hormones so that not only do they have the appropriate part that will lock on to the GLP-1 receptor that's here, but as good as we are with technology, nothing is exactly the same. Maybe their tail is a little bit different, let's just say. But for the most part, our body has become pretty accustomed to this medication. It locks on and activates all the mechanisms within the body that the normal GLP-1 would do, leading to overall fat loss. One of the main concerns with the compounding drugs is that they also have something that may possibly lock on to the GLP-1 receptor, but the tail is completely different. And unfortunately, what happens is our immune system is like, what is the deal with this tail? I now want to make an antibody that's gonna go after the entire thing. So your body's like, this now is a foreign body. Our immune system isn't as sophisticated, and unfortunately what can happen is now it's gonna attack all GLP-1s, even the ones that your body naturally makes. And so one of the concerns behind using medicines that are not FDA approved is that our own immune system is gonna go after not only the medicine that's there, but it will change any natural hormones that we possibly have. This will take a really long time to sort this out with, different models and scientific review, but at this time, we just don't think that it's safe enough to say using these drugs makes that much sense. Of course, we have sympathy for everyone who is scrambling around to find these medications, both by supply and due to coverage and cost. And we hope that we will continue to move forward with a model where we all can get, if necessary, the appropriate medications. Well, thanks, Dr. Egan. I think that that picture was really powerful, and we really wanted to present that data in that capacity, just so people could understand a little bit more of some of our concerns. Again, I really think it's so frustrating, and in some ways, I think that women and any patient, women or man, who's struggling with obesity honestly deserves better than, frankly, a half-assed medication, right? I really believe that we should continue to advocate to get these drugs appropriately covered, as soon as possible for the right patients, because it's honestly biased to take patients who are struggling with weight and just be satisfied with giving them just not as good of a medication. We would not do that for any other disease process, and we would honestly not tolerate it, particularly if it was something like cancer, right? And, patients who are struggling with obesity, struggling with type 2 diabetes, honestly deserve better than a medicine that's sort of halfway working for them and possibly dangerous. So, we've chosen not to sort of work with those medications for those reasons. But I know that's such a difficult choice for patients. And I truly feel for everyone, every woman sort of trying to make that financial choice. And we hope that that day will come when these drugs are much more affordable for every patient. Something that is sort of a bright star in the horizon is because these drugs have been so successful, there's like 15 other drugs that are coming out of different variations, and how this will work will be a little bit like antibiotics. So if you think of the history behind antibiotics, in the early 1900s, we came out with penicillin. And for a while, that's all we had. And we would use penicillin to treat any infection that was in a human body. Now, flash forward, right, over 100 years, and we have a ton of different classes of antibiotics. And doctors will say, okay, what infection is this? Is this pneumonia? Is this a urinary tract infection? Does this patient have meningitis? And we'll choose different antibiotics depending on the disease process that the patient has. In the next 10 to 15 years, I really hope that with more and more medications that are coming out, different doctors will be able to choose different medications to different clinical situations, because we know every patient that struggles with obesity does not have the same biochemistry situation and reason. And we can even see that in the beginning with the basic anti-obesity medicines that are out, right? I would give a patient who was struggling with emotional eating, I'd see success with Contrave, where otherwise I'd see a different patient, I'd have success with Qsymia. And so we already see that a bit with some of the older generation anti-obesity medicines, and we hope that only continues to expand. Of course, as time goes by, the patents will run out and some of these drugs will truly be the generic versions. We also hope to see different medications be distributed for maintenance. So I've had a lot of my patients who have done quite well and are trying to find this new space. What does it mean to actually get to that goal weight that I've wanted to be at? Right? Should I continue using a really potent, powerful drug that has gotten me there? Or should I make a transition maybe to something else? Again, we don't have a tremendous amount of data to talk about these next steps for a patient who's been on a 3 to 5 year journey, weight loss journey, and done well. I think for the very first time, we actually have a direction to go in, and we actually have some choices, because it did feel like forever, we just had patients that were doing yo-yo dieting and just saw that major ups and downs. One of the things that I think, even if you do choose to do compounding medications, we really hope that anyone's working with a medical professional, because one of the other main side effects that I see from these medications is people's hunger really goes to nothing. And it may not even be something that you consciously recognize, but a lot of my patients really have drastically reduced the amount of food that they've eaten. And I tend to see some nutritional deficits, particularly if patients have lost over 15 to 20% of their body weight. So if you're a person that's in that position, you really want to make sure you're working with a medical professional that can help guide you on the appropriate protein intake, nutritional intake, maybe draw some labs if they feel like that's necessary, particularly if you're having a situation where maybe you're losing hair, which is a common complaint that we see, that really can mean that there's some vitamin deficiencies, and it should be really worked out. We worry with vitamin deficiencies not only with hair loss, but also bone loss. Bone loss leads to the disease process called osteoporosis, which can increase your risk of fractures, fractures at your hip, fractures at your spine. And that may not be something you think about if you're in your 40s, but definitely in your 60s, 70s, and 80s, that becomes a really important thing to worry about. And honestly, people can die from hip fractures, and women die from hip fractures and falls. So it's something that later on in life you really want to prevent. Unless there's any questions, we're going to move to our 5 tips to talk so that everyone knows some 5 tips to think about in terms of weight management. All right. Am I a candidate for anti-obesity medications? So you're a candidate for anti-obesity medications if you have a BMI over 30 or are considered to be obese, or you have a BMI over 25 with a comorbidity. This can include high cholesterol, hypertension, definitely prediabetes or type 2 diabetes. Some of the other ones that we think very strongly about are polycystic ovarian syndrome, obstructive sleep apnea, of course, osteoarthritis, reflux. Those are all things that we see that can be weight-related comorbidities. And so anyone may be a candidate. I will say sometimes I'll pull the trigger on a patient who maybe doesn't quite fit that criteria, but have had a rapid weight gain, particularly with perimenopause or menopause. If you're someone who's drastically changed their weight, sometimes we'll pull the trigger and start an anti-obesity medication depending on some other labs. So it's really important you have a doctor who can focus on that and be able to answer that question appropriately. One of the questions was talking about muscle mass loss that is all talking about GLP-1s. Thanks, Kara, for that great question. So one of the things that I want people to know is weight loss from any kind can cause muscle mass loss. Most of our recommendations for weight loss have been dietary changes, other anti-obesity medications, and bariatric surgery. A lot of those things have led to major calorie reduction and major reduction in nutrition that has seen to lead to muscle mass loss. Tirzepatide actually had shown the least amount of muscle mass loss. And I really think this is dependent on how much nutrition you're getting in and how able you are to continue an exercise program and a strength training program. There's some studies that were showing patients who had a good strength training program, meaning were able to lift weights and consistently exercise, had minimal muscle mass loss. I will say that there is no study giving a patient a needed rate of change of weight loss. So if you come to our practice, we really hope to get you into a place where you feel like you have control over your food cravings, you're losing weight, and you're able to continue to eat a pretty consistent diet with lots of protein and other nutrients. And maybe that weight loss is half a pound a week. That's okay. It does not have to be rapid. There's no extra benefit to being rapid. So I would not crank your dose up so high that it completely stopped your hunger so that you just would be like, well, I don't want to eat. I don't want any protein. I don't want to work out. I'm not drinking water. Like I'm too tired. Like those are all the things we're trying to avoid. So we will slow that weight loss down in order to preserve all these other functions to prevent muscle mass loss. I've seen a lot of patients on really high doses, and I get concerned when they come in about muscle mass loss. So I do think it is a possibility, but there are some ways to prevent it. And I don't think it's just this overall slam dunk guarantee 100% that if you start one of these drugs, for sure you're going to lose muscle mass. I think it depends on a lot of different factors. And another factor that's really important is the use of possibly menopausal hormonal therapy. What we've seen is women who get those hormones right around menopause tend to have less muscle mass loss. And I think, unfortunately, in the studies, they kind of group together men, women, perimenopause, menopause, and it's really hard to, and of course, they don't tease out whether or not they are on hormone replacement therapy or not. And so it's really hard to tease some of this out. And so when you look at some of these studies, you're just looking at big averages instead of like really the specific details about a patient. I hope that answered your question. Okay, on to our second. So are you a candidate for anti-obesity medications? Okay, great. One, do I have any, these are tips, the questions they ask your PCP. Do I have any other comorbidities associated with excessive weight? So again, we're thinking about possibly any metabolic issues, which would be issues with your blood sugar, issues with your blood pressure, issues with high cholesterol, fatty liver disease, polycystic ovarian syndrome, or issues with excessive weight in terms of just mass disease. So maybe that's reflux, osteoarthritis, obstructive sleep apnea. Those are all associated with excessive fat mass on our bodies. And then lastly, we think about chronic inflammatory processes, right? So this is like vascular disease, where we've had so much inflammation in our body that's inflamed our blood vessel wall, leading to scarring and obstruction, therefore leading to heart attacks and strokes. So any one of those things could maybe make you a candidate for anti-obesity medications, or definitely would be a comorbidity that would be associated with having excessive weight. All right, number 3, what is your knowledge of anti-obesity medicine? Any provider you're working with, hopefully in 2025, should have some knowledge of anti-obesity medications. I will tell you, and I'll stand by and fight anyone on this, it is not an appropriate answer for them to tell you to try diet and exercise first. That is not the guidelines within the obesity medicine world, and that has not been shown to be proven by science. So, of course, diet and exercise are really an important part of any weight management journey, but by no means is it something that you have to earn an anti-obesity medication. And in particular, if you're someone who's really struggling with a poor relationship with food, you for sure should start an anti-obesity medication to help you along that journey, because it's almost cruel to tell you to eat healthy when you're struggling with excessive hunger and excessive cravings. And so any doctor you work with should at least have an open mind about using anti-obesity medications and getting the right patients on the right meds. Number 4, am I losing too much weight? This is a really important question. And honestly, it's a question in the obesity medicine world I really never thought that I would have to say. But I actually ask my patients this now because it is possible now to lose too much weight. You have to remember, particularly using the NUSH therapy, there's direct action on the fat cells, and that may keep going as time goes on. One of the things us doctors are trying to figure out is how much weight loss is too much. Again, we have those general like boundaries of BMI, but it's something that we're not really sure. If we have a patient whose BMI was 40 and now it's 20, was that too much? We're really not sure. We can track things like muscle mass and body fat, but we're in this quest now to sort of answer that question. I definitely think if you're someone who is continuing to lose weight, particularly, and of course, muscle mass, that it's totally okay to go down on your dose of medication. Remember, we can always give you more if you're someone who starts regaining weight, but we just want to make sure we're not overshooting too much fat loss. And it may be something you'd want to talk to your doctor about, coming down on the medication. This is completely different than a dietary change. A lot of our mindset when we think about losing weight, only thing we can sort of draw our attention to is when we make a dietary change. So if I'm someone who makes a 180 in how I've eaten, right? And I begin to lose weight and my body's losing weight over 6 weeks. And I'm like, yay, awesome. This is working. And then life happens, right? I don't know. I get too busy. My kids are crazy. It's Christmas. Who knows, right? And then all of a sudden, right, I just can't stick to that dietary plan. And all of a sudden my weight keeps going up. Right. And what we see is that rebound. And then sometimes I'll maybe even regain more weight than I would have before. But with these medications, we have more control now. So if you're someone who's responded to them and you're still losing too much weight, we can come down on the dose because we can always give you more back and get you back into a weight losing state if that's what makes sense. But what we don't want to do is really overshoot your weight loss and have you losing too much weight. And again, losing bone mass or muscle mass loss. We don't want to sort of make up other problems worse. All right. Question number 5. How is my nutritional status? Am I a candidate for nutritional labs? So in the bariatric surgery world, they for sure will draw vitamin labs, mineral labs, and they'll do that almost yearly with any post-surgical patient, whether they've lost weight or not. I'm finding in my practice that any patient who's lost greater than 15% of their body weight, and or they're having symptoms such as hair loss, that we will draw nutritional labs, and the majority of the time I will find a deficit in one of those areas. I think it's really important to talk to your doctor about whether or not you want any nutritional labs drawn. You for sure should be on a multivitamin at least, if not other vitamins to help support your nutritional plan. With that being said, there's some other products that have come out to sort of support this journey. At our office, we've chosen to invest in something called BioCare, which is a protein supplementation directly available for patients who are on the GLP-1 medications. They're protein shakes that have all the necessary nutrients in them, with the whole point of just a quick and easy way for you to get in nutrients fast. It can feel like a lot to, I don't know, eat a whole steak and a bunch of other vegetables. And that just may not be something that's on your radar, but you still need to make sure you're getting in the appropriate vitamins and minerals. And that may be something that you'd want to check out and see if you can fit it into your day to day. All right. Next, if there's no more questions, we're going to move on to our 5 tips. All right. We started and we always end kind of this way. What is your picture of self? Right? There is no right or wrong answer to this. It may or may not include weight management. It may or may not include getting your blood sugars under control, but it's always important to do some goal setting in terms of what you want to do. And that can help direct how to move forward. And maybe today is not the day that you're like, I definitely want to try a weight loss medication, but it may be helpful to have a goal. And if you're going through time, right, maybe after 2 or 3 months, you're not meeting that goal, maybe reevaluate if anti-obesity medications are for you. All right. Tip number 2, what is your relationship with food? Every woman, every person should pause and think about this. I would say when I started my journey working through the obesity medicine world, this was brought to my attention. I sort of gave it a really hard eye roll. And I was like, please, right? I don't even want to hear about this. But the more I've gotten involved in some of the neurochemistry and understanding the role of food in our reward center and our impulsivity choices, it's been overwhelmingly clear that the different foods we eat dictate our relationship with food, and our environment dictates our relationship with food. Again, a little bit more of what am I talking about? Even reflect back onto those days where maybe you didn't get great sleep, whatever reason. Busy work schedule, screaming kids, night sweats, right? That next day, like all you can think about is like cookies or muffins or a latte or chai latte, or I don't know, maybe all of it, right? And all of a sudden, all that picture of self about I'm going to eat healthy and I'm going to, treats are going to be just for the weekends goes out the window. And here we are kind of going to town on like ultra processed food with lots of sugars. So don't worry, you're not alone. It's really helpful to just be honest with yourself of where you're at. And then that way we can help determine what to do next. We've made a nourishment journal to help guide women through this, that where you can track your hunger and your cravings and see if there's any relationships to different foods. We've definitely found that patients can find that right plan where they're eating certain whole foods can dictate their cravings later on in the day. For instance, most of the time I've heard good feedback for women who have sort of a protein heavy first meal tend to have less cravings in the evening. So believe it or not, a lot of the times that we hear about cravings is, you've already had dinner, the kids are in bed and it's quiet. And like all of a sudden now we're like, I need popcorn, I need chocolate, I need ice cream. That's a craving. Slow down and say, 1, it's always best to be self-forgiving, right? We're working with what we got, and that's where our brain is. But 2, what did I do throughout the day, the night before and the day that's led me here? And can I make any small changes tomorrow to help not make these cravings so strong? So please check out our nourishment journal and our mindful eating guide, and that can be really helpful if this is something you're struggling with. I also think it's really helpful for even patients on the GLP-1 medications, because what we've seen over time is initially people will have really strong control over their cravings for about the first 6 months. And then those cravings can slowly start creeping back. And if you're someone who is really plagued by really strong cravings, that can feel very frightening. And so it's always important to start working on this relationship with food, always, to continue to build the appropriate structure for a weight management plan that includes food, your brain, exercise. That all is still so important, even with use of these medications. Number 3, consider an anti-obesity medication. So maybe you're someone who whether due to cost or side effects, the NUSH therapy is not for you. There's a lot of other anti-obesity medicines that are really impactful. We've seen some good success using even metformin, which is a drug that we use for type 2 diabetes. We have a lot of good success with Qsymia and Contrave. There's some other good choices, and it's worth maybe thinking about using some of those if you want to just get started and work a little bit with maybe your relationship with food or binge eating. It can always be a great conversation. Number 4, are your medications safe? Again, I have such empathy for everyone who's trying to make these choices about cost and getting them covered. Just make sure you're reflecting on where you're getting your medications and whether or not you're being appropriately covered in terms of not only where they're from, but are you being monitored safely for your nutritional status and your weight status and making sure your muscle mass is holding. So these medicines are very potent, and you just want to make sure that you're not making a problem for yourself further down the line. And time will tell as we go on about different patients and different classes of who should be using these. So just if you're using any medication, you just want to make sure it's safe and the right choice for you. All right, number 5, what is the right weight for me? I hope that we've talked a little bit about how this is a bit of a shrug, and some of this will be about you and your thoughts. I actually have moved away from my patients in even thinking about weight. And as time has gone on for my patients who are using anti-obesity medicines, I started asking them some other questions, right? Some of the questions I ask my patients are, what's your relationship like with food? How are your cravings? How is your hunger? Does it feel controlled? Does it feel that you're having a good deal of satiety? 2, how do you feel in your clothes? How do you feel in the mirror? Do you have confidence, right? If you're B-minus 30 and you just love the way you look, that's it, right? You're okay with that. That's an okay place to be for you. Number 4, what's your metabolic health like, right? Let's make sure we're checking your blood sugars and your cholesterol levels and your liver enzymes and all those things that we check and make sure need to be in order. And then number 5, are you able to be active? If you still have enough weight where it feels like it's too heavy to meet all your activity goals, then maybe it would be appropriate to lose a little bit more weight, right? But maybe you feel like you can do everything from an activity standpoint, you feel hydrated and you have lots of energy, then maybe you don't need to lose any more weight. So again, there's not one right answer for every woman. I would kind of throw BMI out of there as something that I'd reflect on. And I hope that women can break free of the scale number that we have, because there's so many other factors that are impactful in terms of how we measure success within this space. All right, unless there's any other questions, I am going to sign off. I love talking about weight and weight medications and food and how it's impactful in our lives. So if you'd love to come see us, you can check us out at truewomenshealth.com. We're available, of course, in the state of Michigan, and we have a lot of telemedicine capabilities in a lot of other states. And we have some online programs that can be helpful as well. So everyone have a good night, and you know how to get a hold of us if you have questions. Thanks.